Welcome to EYETALK, an interview program about current issues and controversies in ophthalmology. I'm Natalia Shilova. Postkeratoplasty astigmatism remains a challenge for corneal refractive surgeons. While maintaining a healthy graft is a crucial issue in keratoplasty procedures, astigmatism is a limiting factor in the visual rehabilitation of otherwise successful corneal grafting. And today we are here with Professor Irit Barequet from Tel Aviv, Israel, to discuss that question. Irit, welcome to EYETALK.
Thank you.
And my first question to you will be, which options nowadays exist for the treatment of postoperative emmetropia and astigmatism in the patients following PKP or DALK?
Well, this is a very important question because, as you mentioned, many times we achieve a beautiful, clear corneal graft, but patients suffer from either astigmatism or myopia, sometimes hypermetropia, and many times an isometropia that actually doesn't allow fitting with the glasses for visual rehabilitation. So we end up with a clear graft, but visual impairment and the visual rehabilitation is limited. So we can address astigmatism, which is actually the most common cause of visual imperfection after keratoplasty. But astigmatism treatment doesn't address the refractive error. So we need to many times combine treatment of astigmatism with a refractive error treatment. So for astigmatism, we use radial keratotomy, either manual or by femtosecond laser. And for the refractive part, in many cases, we use the excimer laser treatment to improve the spherical part of the emmetropia.
It would be interesting to know what is the preference method of suturing. Do you usually use a continuous suture or interrupted ones? And do you think this issue really has a significant impact of postoperative astigmatism?
Well, years ago, I used to try to get the best continuous suture possible and adjust intraoperatively. I don't like to adjust postoperatively because I'm very afraid of some infections penetrating. So in the latest years, I use single interrupted sutures that allow me to start visual rehabilitation earlier on with selective suture removal. Since the grafts are very precious and we want to spare any option of the current graft, looking at selective suture removal after 4 to 6 months, depending if it's DALK or penetrating keratoplasty, allows for early visual rehabilitation. Also, at the end of the procedure, I always try to ensure that there's balanced suturing, no significant astigmatism. Hopefully, the scar will create in a quite regular manner.
That's great. If we are talking about laser technology, which method will be more suitable for the treatment of postoperative astigmatism? Probably LASIK or LASIK or PRK?
Well, PRK in all the variations, if it's alcohol-assisted or manual or in transepithelial, seems quite attractive because you don't need to touch the cornea or cut the cornea. But the problem is that many times it's associated with significant haze that is mostly related to the magnitude of ablation and is also associated with refractive regression and decreased best corrected visual acuity. Mitomycin C improves the results, but still there's haze and also the risks for rejection. So the treatment with steroids need to be more prolonged. And the results are suboptimal. They're less optimal than with PRK in regular eyes when it is performed. Now with LASIK, with a microkeratome, you don't control so well the margins of your flap, and sometimes you need to involve also the graft-host junction. This changes the mechanical forces in the cornea and the biomechanics and can affect the visual result and the treatment of the emmetropia. So mostly we prefer using the femtosecond laser for femtoLASIK, and we perform the flap inside the graft margins, allowing us to control very well the graft margins, to avoid touching the graft-host interface, and by this we avoid dehiscence, we avoid any vascularization or any affecting on the mechanical part, the biomechanics of the cornea. And then we perform the excimer laser ablation within the graft margins and reposition the flap as in any femto LASIK procedure.
Mm-hmm. Who would you think will be the best candidate for laser treatment?
Well, this is a very, very good question because it's tempting to approach any patient after keratoplasty. So many times patients want the keratoplasty and want to be visually rehabilitated. And if it's possible to achieve this with glasses, then they're happy. But glasses have, of course, a very limited implication in these patients. So then they mostly don't want to go back to contact lenses because they mostly have a bad experience with contact lenses prior to the surgery. So they are looking many, many times for a refractive procedure that can help them be independent of glasses and visually rehabilitated. So still, these patients need to have a clear graft, a very good healing of the graft-host interface, no vascularization, no sutures anymore, and also have a good endothelial function that is adequate to show that the endothelial cells are good. Regular astigmatism are, of course, the best patients or patients that have very minimal astigmatism. But even with slight irregular astigmatism, it may be many times controlled by topo-guided ablation with the excimer laser.
How long would you normally wait after corneal transplant surgery before suggesting laser surgery? And is there any contraindication or limitation for laser surgery in such a group of patients?
So I usually wait at least a year after the keratoplasty to ensure a stable graft-host margin, stable refraction, stable topography. I remove all the sutures prior to the refractive procedure, and I wait between 3 to 6 months after complete suture removal to make sure that the surface is stable and the refraction is stable.
One of the surgical options which nowadays is gaining popularity, it is intrastromal segment implantations in patients after penetrating or keratoplasty. So, in several studies has shown that this technique yields a good visual rehabilitation and visual outcomes and topography results as well as a laser technique. So, would you consider this technique sufficiently safe? And in your opinion, this technique, can it replace the laser surgery in the cases with a high astigmatism after PKP?
So, first of all, if the implants are applied, then the channels should be performed with the femtosecond laser to ensure exact position by depth and location. But since in many of the cases you would like to implant the intacts or any implants within the graft margins, then sometimes there is a limitation of the amount of correction that you can achieve. And also studies have shown undercorrection, significant undercorrection, probably because you deal with a different cornea than the results that we see with keratoconus prior to penetrating or bulk. So in many cases, implants are applied when you want to refrain from an excimer laser procedure or in addition to an excimer laser procedure to address the astigmatism part. But if you want to address also the spherical equivalent in complete overlook, then it's probably preferable, in my opinion, to proceed with an excimer laser procedure.
Irit, thank you for coming. Thank you for interest in EYETALK. It was Shilova Natalia and our guest Irit Barequet.
Thank you.